Anya has had a fall and been admitted into the hospital emergency department in the early hours of the morning. She is drowsy and distracted. She tells the doctor that she takes 5 milligram blood thinners twice a day because her heart beats too fast. The doctor is unable to fully access Anya's shared medication record to confirm what the medication is. They are also unable to ring the GP surgery as it is out of hours. He decides to contact the on-call pharmacist to check which blood thinner might be prescribed. The pharmacist reviews the patient's previous hospital history, local formulary guidance, and completes some clinical checks before suggesting apixaban. The doctor prescribes apixaban 5 milligrams on the Electronic Prescribing and Medicines Administration System, EPMA, manually keying in the prescription details. Because the hospital systems are not interoperable, these additional steps take longer and opens the process up for more opportunities for error. Anya is admitted for an overnight stay for pain management and an X-ray tomorrow. The nurse admits Anya to the ward and notes that she is taking apixaban. The nurse sees that the next administration is due in the morning. She manually checks the ward stocks and identifies that a supply of the medicine will be required. She leaves a note for the pharmacist to review the prescription and make a supply when they get to the ward. The following morning, the nurse on shift sees that a note has been left to order apixaban for Anya, a medicine she is not familiar with. The hospital EPMA system is not dm+d enabled, so without the ability to identify and check on the medicine information electronically, the nurse instead has to look it up manually. This introduces additional delays and increases the risk of error. At the morning medicine round, Anya misses her dose of apixaban as there is still no stock on the ward. The pharmacist has not got to the ward yet, so the nurse contacts her urgently to review Anya's medicines, as no supply can be made until the pharmacist has clinically reviewed the prescription. Missed doses and delayed treatment could introduce potential patient harm. Anya is feeling much better, and all of her test results have come back. Her ankle is severely sprained, but she is keen to go home. After the consultant ward round, her take-home medications are written on a discharge system and then printed to be sent to the pharmacy for dispensing. Anya's dose of apixaban has been reduced. This information needs to be safely transferred to the GP to follow up on discharge. When the prescription arrives in the pharmacy, it is clinically screened by a pharmacist before the prescription and labelling details are manually keyed into the dispensing system. The nurse cannot tell Anya when her prescription will be ready. Anya is expecting to go home today and is becoming annoyed and frustrated at the delay. Anya is recovering well at home, but needs some more pain relief and to order her regular medication. She calls her GP practice and waits for the prescription line to be answered. Eventually, the GP practice picks up the call. The practice team explains that they have not yet received the discharge letter from the hospital. They will have to contact the ward or the hospital pharmacy to confirm what medication is required. Anya is given the option to call back in a couple of days to check in again, or if she urgently needs her medication, to bring in her pay-for-discharge copy to the surgery. A healthcare professional can then transcribe her medication to the GP records to allow a repeat prescription to be ordered. She calls back a couple of days later and is told the surgery has received the discharge letter and can generate a prescription for her. The prescription is sent automatically to the community pharmacy of her choice, and she collects it within 48 hours of ordering. When dm+d is used in clinical systems, it can enable a seamless information flow, a transfer of care across multiple healthcare settings, making care for people safer and more efficient, and allowing clinical teams to have more time to care for patients by removing the need for medicines to be transcribed from one system to another. When adopted, dm+d ensures the same descriptions are used for medicines across care settings, reducing the risk of misinterpretation. It means that prescription information can be presented where and when it is required, meaning patients don't have to remember what can be complex information or share it repeatedly every time they engage with the NHS. When used by everyone, dm+d will support patient-centered consolidated medication records, access to the electronic prescription service, and enable patient-focused innovations that we haven't even thought about yet. Efficient, effective, safer. dm+d. Unlock safer care.